Okay, let's continue from where we ended. Good. So we are going to look at the concept of anion gap. Okay. Now the anion gap is telling us about so sorry the anion gap is telling us about um, the difference between the cations and then the anions in blood plasma. Okay, that's basically the idea. The difference between the cations and the anions in the blood plasma. Okay, and we are assuming that since the abundant cation is sodium, so we are using sodium to represent the cations. Okay, and then we are going to use chloride and then bicarbonate to represent the anions. So what we are going to do is that when we get the concentration of sodium, we subtract we are going to add the concentration of the anions, which in this case we are using chloride and then bicarbonate. So we will add the concentrations of chloride and carbonates together. Okay, then we subtract that from the concentration of sodium. The difference that we are going to get is what is called the anion gap. Okay, but the assumption here is that sodium is the most abundant cation. Okay, and then the anions are chlorides and then bicarbonates. Okay, good. So what's going to happen is that within for the anions, okay, the anions, let's say the anions are 100%. Okay, and let's say if I add chloride and then bicarbonates together, okay, and let's say that gives me 80%. Okay, that gives me 80%. Now I'm going to use the 80% to represent all the anions. So that means that I don't consider other anions. I don't consider the phosphates. I don't consider the sulfates. I don't consider all the other anions. I don't consider proteins. I don't consider any of the anions. I'm only considering chloride and then bicarbonate. Okay. So if there is any condition in which the phosphates levels increase, in which other anions increase, other anions like um, phosphates, other anions like sulfates, other anions like keto acids. If you remember the keto acids, okay, from diabetes, keto acids, the beta butyrates, the acetones, and the acetoacetates, they are all anions. Okay, if their levels increase, what's going to happen is that that is going to decrease the amount of sodium, the amount of chloride and then bicarbonates. Okay, so that means that if I calculate my anion gap, the anion gap will increase because the anion gap is only using chloride and then bicarbonate. It's only using chloride and then bicarbonate. So if the chloride and the bicarbonate concentration reduce, then if you look at this mathematical equation, sodium minus this factor, okay, if this factor decreases, then the anion gap will increase. How does the chloride and then the bicarbonate levels decrease? These levels will decrease when the other anions level increase. The other anions are sulfates, phosphates, lactates, acetoacetates, and then the beta hydroxybutirates. Okay, when these levels increase, chloride and then the bicarbonate level will decrease, and hence the anion gap will increase. So anytime you hear that the anion gap has increased, two things should come to your minds. Okay, one is that the levels of sodium and bicarbonate have reduced, and the second thing that should come to your mind is that the levels of the other unmeasured anions like sulfates, phosphates, lactates, acetoacetates, beta hydroxybutirates have increased. Good. So if you get a condition like diabetes DKA, okay, which is diabetic ketoacidosis, where you have high levels of the keto acids, which are acetoacetate and then beta hydroxybutyrate. So someone with diabetic ketoacidosis will have an increased anion gap because the unmeasured anion levels have increased, and that's going to reduce the levels of the chloride and then the bicarbonates. 2, if someone has lactic acidosis, that means that the person's lactate levels have increased. So this person will also have a reduced chloride and then bicarbonate level. And when the chloride and bicarbonate levels are reduced, the person will have an increased anion gap. Okay, so that's the concept of anion gap. Good. So I'm not really going to talk about the chlorines, okay, because those ones are not. It's not anything much. The hypokalemia is usually seen in vomiting. Someone who vomits. If you vomit a lot, you lose a lot of chlorine, okay? Because remember that anytime someone vomits, okay, the person is vomiting HCl because HCl is produced in the stomach. So if you vomit, you are losing both acid and you are losing both chlorine. Okay, that's one concept that you should have. Okay, and someone with hyperchloremia, that one is usually when you are giving the person IV fluids. Okay, sodium chloride, when you give in excess, their chloride levels will increase. Good. Someone has a question.
Right, please. Does that mean that the anion gap is mainly dependent on the concentration of chloride and bicarbonate?
Come again.
Does that mean that the anion gap
Yes.
is mainly dependent on the concentration of chloride and bicarbonate?
It's mainly dependent
On the concentration of chloride and bicarbonate.
You can't say that because the concentration of the other anions, okay, the unmeasured anions like lactate and then the other ones, they would also influence or affect the concentration of the chloride and then the bicarbonates. Okay, so you can't really say that. Okay, so it depends both on the chlorides, the bicarbonates, and then the other anions, because the other anions will affect the chloride and then the bicarbonate concentrations, which is used in the calculation. Please, is it clear?
Yes, please.
Okay,
Thank
good.
you.
You're welcome. Okay, now let's go to potassium. Let's go to potassium. Now, potassium levels are very critical in the human body. Okay, now note that we said the most abundant cation inside the cell is potassium. Okay, but the potassium which is outside the cell is very small and it's between 3.5 to 5.5 millimoles per liter. That's the concentration. So that means that is a very strict range, 3.5 to 5.5. Unlike sodium that we saw was 135 to 145, a difference of 10. When we take potassium, it's 3.5 to 5.5, which is a difference of 2. So that means that the potassium levels is strictly regulated. Anytime you have problem with your potassium levels, like it's going to affect all the organs that require electrical activities, like the heart and then the brain and then the muscles. Okay, so that is why deficiencies or abnormalities in potassium levels affect the person's heart. It can lead to arrhythmias. Is it clear? Okay, good. So let's see. Okay, we've talked about all these things. Let's look at the pathophysiology of disorders of potassium. Now, there's a concept that I want to introduce. There's a concept I want to introduce. This is very important. Now, anytime you see, there's a relationship between potassium and hydrogen. Okay, potassium and hydrogen ions. Anytime you have high hydrogen ions, okay, what's going to happen is that the hydrogen, there's a transporter, okay, there's a hydrogen potassium transporter. It's an antipode. What's going to do is that it's going to shift the hydrogen from from the plasma into the cells, okay, and then shift potassium from the cells into the plasma. So you notice that if a person is acidotic, okay, someone has acidosis, the person is more likely to become hyperkalemic. Is it clear? Please, I need 2 responses so that I know you are following. Is it clear?
Please, can you go over?
Please take it
Please
again.
repeat.
Okay, let me repeat. So I'm saying that there is a relationship between potassium and then hydrogen, okay? If someone, I mean, I'm talking about in the extracellular fluid. If someone has a lot of hydrogen H plus in the extracellular fluid, okay, the person doesn't want the H plus to increase. Later on, we will know why. So what's going to happen is that the H plus has to shift into the cells. And as the H plus, which is the hydrogen ions, shift into the cells, potassium ions must come out because it's an antiport system. Okay, so if someone has high levels of H plus, if someone has high levels of H plus in the person's blood, we should be conscious of the fact that potassium is more likely to leave the cells into the extracellular fluid, and hence increasing the blood potassium levels. Okay, that is a very important concept between hydrogen and potassium. So that's the reason why most often than not we will say that if someone is acidotic, the person will have hyperkalemia. Okay, good. And then the opposite too is true. If someone has low levels of H plus, okay, then H plus must move from inside the cell to the outside of the cell. And as it does so, potassium will move from outside the cell to inside the cell. Okay, so it's like an antiport system. Okay, good. Now, the second concept I want to mention is this, that whenever you have insulin, okay, a lot of people know is that insulin just enables cells to absorb glucose. It's not only cells. I mean, it's not only glucose, okay? Insulin too can cause ions to move into the cells. So insulin can cause one, glucose to move into cells. 2, it can cause potassium ions to move into cells. 3, it can cause amino acids to move into cells. Okay, good. So the fact is this, I'm saying this because later on I will tell you that if someone has high potassium levels, you give the person insulin, and then the insulin is going to shift the potassium from the plasma into the intracellular compartments. Okay, so I've given you 2 principles. One, the principle between potassium and then hydrogen. 2, the effect of insulin on potassium. Okay, now the third principle I'm going to give you is the effect of aldosterone on potassium levels. Now, if you recall from yesterday, we said that what aldosterone does is that aldosterone leads to reabsorption of sodium at the expense of potassium and then hydrogen. Okay, so if you have high aldosterone levels, that means that you are going to lose a lot of potassium in your urine. So all the conditions that come with high levels of so all the conditions that come with high levels of aldosterone will lead to a situation where you are going to reabsorb sodium. So if you reabsorb sodium into your blood, you have high sodium level, which is hypernatremia. 2, it's going to cause them to lose potassium. So if you lose potassium, the potassium levels in your blood will go down. So hypokalemia. 3, it's going to lead to loss of hydrogen ions. So you get alkalosis. Okay, so the effect of excessive aldosterone is hypernatremia, hypokalemia, and metabolic alkalosis. So remember these 3. If you have high levels of aldosterone, you are going to reabsorb a lot of sodium into your blood, so you get hypernatremia. Two, you are going to lose a lot of potassium in your urine, so you get hyponatremia. Three, you are going to lose a lot of acid. If you lose a lot of acid, your blood will become alkaline. So you are going to get alkalosis. Okay, so that's the effect of aldosterone on potassium. Good. So so with this, we can move on to potassium disorders. So the first one we are going to look at is hypokalemia. Before I continue, anyone with any question so far? Okay, so I assume we are all okay with it. Good. So now let's go to causes of hypokalemia. So hypokalemia, it means that um, the person has potassium levels less than 3 millimoles per liter. Okay. Now the clinical features of this, as I said, is going to affect tissues that require electrical activities. So it's going to affect muscles, neurons, and then the heart. Okay. So for the heart, it will cause arrhythmias. For the neurons, it will cause hyporeflexia. And for the muscles, it will cause muscle weakness. Okay. So these are the organs that uh, these are the organs that are affected by potassium levels. Okay, good. Now the ECG changes. Okay, this one maybe for the clinical year student. Notice that if you have low sodium level, the T waves are flat. Okay, and then the U wave will be prominent. So there's flattened T wave and then prominent U wave. Okay, that's something that you should know. What can cause hypokalemia? So, like all the other principles, one, inadequate intake. Okay, this one is not common. Okay, but the commonest ones are the GIT losses and then the renal losses. As we saw again, someone with vomiting, someone with diarrhea. Okay, renal losses. Renal losses. Okay, so for renal losses, we have to understand that in aldosterone, if you have aldosterone is going to cause reabsorption of sodium and then excretion of potassium. So any condition that leads to high aldosterone levels, okay, Crohn's disease, okay, or even the mineralocorticoids and then the glucocorticoids, okay, Cushing's disease. So they all present with hypokalemia, okay, good. And then sometimes too, we give certain, I talked about certain drugs that inhibit aldosterone, which is used in management of hypertension, okay. So those ones, including diuretic drugs, okay, diuretic drugs. So most of the diuretic drugs, okay, will cause hypokalemia. Most of them will cause hypokalemia, but there are a special group of diuretic drugs that don't cause hypokalemia. So we call those ones potassium sparing diuretics. Okay, that's why if you've learned drugs for diuretics, okay, or diuretic agents, you notice that we have a special class we call potassium sparing diuretics. The fact is that most of the diuretics will cause how do you call it, hypokalemia, but the special ones are called the potassium sparing diuretics. Okay, good. And then there's a fourth point over here which I have emphasized. Okay, that's what can cause hypokalemia. Okay, is when the person has the person is in the alkalotic state. Okay, that means that the person's blood is more of alkaline. So that means that acid must move from the cells to the bloodstream. Okay, so the acid will move from the cells to the bloodstream, and once the acid moves from the cells into the bloodstream, potassium will shift inside the cell. So when potassium shifts into the cell, then you are going to also get hypokalemia. Okay, good. We are done with hypokalemia. How do we manage hypokalemia? Okay, you have to give the person potassium. Okay, so the potassium usually we give potassium chloride. Okay, usually, and one thing is that it should not exceed 20 millimoles per hour. If you are giving the person potassium in 1 hour, you have to give them a maximum of 20 millimoles. This one, if you come to the clinical years, they'll be asking, they'll be mentioning this that don't exceed 20 millimoles of potassium per hour. And as a doctor, you must know this. This is something that you must know. Okay, and then in a day, you don't exceed 140. This one, every doctor knows, so keep it in your mind that don't exceed 20 millimoles for 1 hour. And then the whole day, the amount of potassium that you are giving to the patient, it should not exceed 140 millimoles. Okay, good. The potassium we use is potassium chloride. When you come to the ward, we have a lot of them there. Good. Now we are done with hyponatremia. Let's go to hyponatremia. Let's go to hypernatremia. Now, when we take hypernatremia, we are almost done. When we take hypernatremia, okay, which is high levels of potassium, high levels of potassium. Now, you see, if you have a lot of potassium, it's also going to cause how do you call it, effects on the neurons, the hearts, and then the muscles. Okay, but the most feared effect is the effect on the hearts, because it can cause atrial fibrillation, dangerous arrhythmias. Okay, and then on ECG, the difference between the hypokalemia and then the hyperkalemia is that we saw that for the hypokalemia, the T waves become flat, but for hyperkalemia, the T wave become very long. So we say we have a peaked T wave. Okay, so the first thing that you see is the peaking of the T waves. Okay, then another strange thing happens. The P wave will also disappear. Okay, then the final thing that will happen is that you have abnormal QRS complex. Okay, so peaking of the T wave is the first ECG sign of hyperkalemia, followed by absent P wave and then abnormal QRS complex. Okay, good. Now, what can cause hyperkalemia? Okay, now the first thing that can cause hyperkalemia is actually force or force mechanism of taking blood sample. Okay, if you take blood sample, okay, and then the agents you used, okay, hemolyzes the red blood cell. We know that we have a lot of potassium inside the cell. So if there is hemolysis of the red blood cell, the red blood cell is going to release its potassium into the sample that you've taken. So when you measure it, you assume that this person has hyperkalemia, but it was as a result of force method of taking the person's blood sample. Okay, now for the genuine causes of hyperkalemia, okay, the first one is adequate or excessive intake. If you are taking in a lot of potassium, okay, and they say potassium is in banana. So if you are eating a lot of banana and then you can't excrete it, okay, in people with kidney disease that can't excrete the potassium, then they will have hyperkalemia. Okay. The second thing is, for example, in the treatment of hypokalemia, I said you give the person potassium chloride. If you give the person excessive potassium chloride, then you can get how do you call it? You can get hyperkalemia. Okay. 3, I'm sure you guys are you've done hematology. You know that one of the transfusion reaction, when you give blood that has been stored for a very long time, it tends to hemolyze, and then when you give it, one of the transfusion reactions is actually electrolyte abnormalities. Okay, that is hyperkalemia. Okay, but as I'm emphasizing, most of the potassium are stored inside the cell. So another common cause of hyperkalemia is people with cancer. You see, cancer means you have an abnormal growth of cells. Okay, if you are giving people with cancer, okay, chemotherapy agents, the chemotherapy agents is going to kill the cancer cells and release the potassium inside the cells into the person's bloodstream. Okay, not only the potassium but also the uric acids. Okay, this is a condition which is feared. Okay, so if you give the person how do you call it, um, over here, okay, if you have tumors during treatment of tumors, okay, you cause these kind of reaction. Okay, and one effect is hyperkalemia. Good. And also, well, as I said, if you have metabolic acidosis, you shift. If you have metabolic acidosis, you have a lot of acid in the blood, so you want to shift the acid into the cells. As you are shifting the acid into the cells, potassium will come out. Okay, so this is the internal shift mechanism. So this is for the clinical use unit. Anyone with diabetic ketoacidosis. So for diabetic ketoacidosis, we've seen one thing already, that it can lead to an increase anionic gap. The second thing that you should know is that people with diabetic ketoacidosis are how do you call it? Can have hyperkalemia. They can have hyperkalemia. Okay, they can have hyperkalemia, but mostly they have hypokalemia. So they can either have hyperkalemia or hypokalemia, but mostly it's hypokalemia that they have. Okay, because diabetic ketoacidosis leads to production of aldosterone. Okay, and we saw that aldosterone will cause elimination of potassium. Okay, so just know that diabetic ketoacidosis mainly causes hypokalemia, but it can also cause hyperkalemia. Good. And then the commonest cause of hyperkalemia is renal failure. Okay, someone with renal failure, you cannot excrete the potassium, so it accumulates in the system. Okay, and I've also talked about Addison's disease. Addison's disease is when you don't have a lot of aldosterone. If you don't have aldosterone, you cannot reabsorb sodium. Okay, and at the same time, you cannot excrete potassium and then the H plus ion. So people with Addison's disease would have one, hyponatremia, two, hyperkalemia, three, metabolic acidosis. Now, management of hyperkalemia, there are 6 ways of managing someone with hyperkalemia. Hyperkalemia is a very dangerous thing to do. I mean, it's a very dangerous condition to have. Okay, and to manage. I mean, you will learn more about this later on. Okay, all of them must be put on ECG so that we monitor the ECG changes. The ECG changes are peaking of the T wave, loss of the Q wave, and then QRS complex abnormalities. Now, the first thing you do is to give them calcium gluconate. Now, we say what the calcium gluconate does is that the calcium gluconate stabilizes the myocardial tissue. Okay, the calcium gluconate really does not solve the hyperkalemia issue. What it does is that it stabilizes the myocardial tissue so that the person does not get arrhythmias. So that's the first thing we do. Calcium gluconate is the rule of 10. 10 mL of 10% calcium gluconate given over 1 minute. Okay, so 10 mL, that's the rule of 10. 10 mL of 10% calcium gluconate given over 1 minute. And as I said, the function is to stabilize or give protection to the myocardial tissue. Now, the second thing we do is giving glucose and insulin. I mentioned that insulin can take potassium into the cell. So you give the patient glucose as well as insulin, okay? And that insulin is going to shift the glucose and the potassium into the cells, okay, managing the hyperkalemia. The third thing we can do is we give the person salbutamol. Okay, salbutamol also works like insulin. Okay, so when you nebulize the patient with salbutamol, you also shift the potassium into the cells. Okay, the fourth thing you can do is what is called the ion exchange. Okay, so you give them certain medications, okay, which causes them to excrete a lot of potassium. Okay, so example of the ion of such drug is what's called the resonium. It's over here, resonium. So it's what is called resin ion exchange, resin ion exchange, RESIN, ion exchange. Okay, then the fifth thing you can do is you can do dialysis. Well, you put them on the dialysis machine. Either either you do the peritoneal dialysis, or you do the how do you call this, the blood vessel type of dialysis. Okay, good. And then the last thing is if the person's, as we said, chronic CKD, the chronic renal failure, is the leading cause of hyperkalemia. If you've done all these things and then you can't manage it, then you finally do kidney transplants. Okay, so we are done with the electrolytes. We've talked about sodium, we've talked about chlorine, we've talked about potassium. Okay, so you end here, and then in the evening we'll start with the acid-base balance. Okay, then maybe tomorrow we'll do the renal pathology. Okay, I don't want to exceed 1 hour so that you guys can get time to do your revision. So we'll do it little by little, but I promise you that we will finish all of them. Okay, please, any questions?
Bryce, please, I want you to kindly go over the chloride part.
You said I should go over which parts?
The chloride.
The chloride.
Yes, please.
Okay, so I said that the chloride is not really a big deal. Okay, so even if no one will ask you questions about it, but then you can get low levels of chlorine. Okay, and that one is usually also as a result of GIT losses. Okay, for someone who is vomiting. And I said when you are vomiting, because the stomach has HCl, when you are vomiting, you lose a lot of chlorine. Okay, so it's over here. So chlorine is seen, hypokalemia is seen when a person loses, the person loses chlorine as a result of vomiting. Okay, and we have hyperkalemia, and hyperkalemia, that one we see it when you are giving the person infusion, sodium chloride infusion, and then when you overgive it, okay, you increase the person's chloride level. Please, are you okay?
Yes, please.
Good.
So does it mean it can also lead to hypernatremia?
Yes. So the two usually occur
Okay.
simultaneously.
Okay, thank you.
Yes. Any other questions?
Guys, please, you said three things about cons. You said hyponatremia, what and what?
Come again.
You said three things about cons. Like in Cons syndrome, there's hyponatremia. I think you said metabolic acidosis and something else.
Yeah.
Is it
So for Crohn's disease, you have high levels of aldosterone. Aldosterone is going to lead to reabsorption of sodium. Okay, and excretion of potassium and then hydrogen. So it will cause hypernatremia, hypokalemia, and then metabolic alkalosis. Okay.
Okay, thank you.
Welcome.
Right.
Any other questions?
Yes, please. Right. Would that be the same for Cushing's syndrome?
Yes. So because the reason is that when you take the hormones which are produced from the adrenal cortex, okay, the mineralocorticoids and then the glucocorticoids, which are seen in Cushing's syndrome, they also have aldosterone effects. Okay, so if you have a lot of cortisol, a lot of mineralocorticoids, okay, they can also exhibit aldosterone effects. So they can also lead to reabsorption of sodium, excretion of potassium, and hydrogen ion. So Crohn's disease and then Cushing's disease, their electrolyte pictures are almost the same. Okay, we have 1 minute more. Any other question?
Yeah, Bright.
Yes, please.
Please, can you go over the anti-symphoter again?
Okay, so I'm saying that hydrogen and then potassium are like they use a certain antipode. Okay, so if you have more hydrogen in your blood, we don't want more hydrogen to be in your blood, so your blood will want to push the hydrogen into the cells. As it pushes it into the cells, okay, the transporter will push potassium out of the cells. So acidosis will eventually cause hyperkalemia. So because potassium will come outside as a way of compensating for the excess hydrogen ions. You want to shift the hydrogen inside, but as you are doing that, you also bring potassium outside, okay? And vice versa. Okay, our time is up. We will end here. We will continue in the evening with acid-base disorders.